Next slide. So, as what I said before, lung tissue damage and also mucus hypersecretion will begin to obstruct and narrow down the airway. So, in this case, we can see patient expiring with pursed lips. So, expiration with pursed lips is a technique which consists of patient inhaling through the nose and exhaling through the mouth at a very slow, controlled flow. So, this technique allows patient to have control over their oxygenation and ventilation by prolonging the rate of. Sorry, I had okay. Sorry, I had some speaker problem. So as what I was saying, pursed lips breathing helps patient to have proper control over the oxygenation and ventilation. So this technique supports breathing by creating an opposing pressure against the positive pleural pressure that squeezes on our airways during exhalation. So this pressure is known as our positive and expiratory pressure, or known as PEEP. So this will help to keep the airways fairly open and not further contract and narrow it. So it is known to relieve patients' shortness of breath and work of breathing temporarily. So in cases of obstructive airway, patients are also seen to be using breathing using their accessory muscles like the sternocleidomastoid muscles or scalene muscles. So the neck muscles can be seen contracted and also patient in tripod sitting position. Tripod sitting position is where patient is sitting upright and the hands are fixed on a surface or their knees commonly to activate the pectoralis muscles so the patients can help with expanding their thoracic cavity and breathe better in cases of severe dyspnea. Next thing is decreased ventilation leading to hypoxemia and hypercapnia can cause cyanosis in patients, which is the bluish discoloration. And turbulent airflow in narrow obstructed airways, wheezing on expiration can be heard on auscultation. So besides all these clinical features that I've already presented, there are also some other features like fatigue due to reduced oxygenation to tissues. So over time, which can become chronic, resulting in reduced physical activity, muscle wasting, and weaknesses in patients. Next. So as what I've explained before, this is the tripod position. As you can see from the picture in the left, there's two types of position. One patient's hand is on the table and another one is a common one, patient's hand on the knees to help expand the thoracic cavity and breathe using the help of the pectoralis major muscle. And the picture on the right is a pursed lips breathing. The patient is inhaling through the nose and exhaling through the mouth at a slow controlled flow. Next slide. That's all from me. Thank you very much. Any questions? No. Okay, then I'll move on to the next presentation. Thank you.
Right. Assalamualaikum and very good morning to doctors and all my teams. So my name is Muslim bin Syed. So I'm going to proceed with the investigations of COPD patients. So whenever you encounter patients with a history of chronic cough, sputum productions, dyspnea, and also history of smoking, you should put COPD one of your diagnoses besides of the other differential diagnoses. So there are several investigations that we can run to diagnose the COPD. The investigation, next slide please. So the investigation would be the first one, lung function test, which is consists of spirometry test and also peak expiratory flow meter. And there also additional test, which is really helpful in terms of managing future management of the patients and also to rule out any differential diagnosis, which I'm going to briefly explain every single of it on my next slide. Next slide, please. So the first one will be spirometry test. which is more specifically called, or more specifically towards the bronchodilator reversibility test. So whenever patients that exposed to risk factor and also have a sputum production, we should run this test. So to conduct this test, we have two sessions, which is pre and post bronchodilator administration. The reason we do the reversibility test is to differentiate between COPD and also asthma, because most of the time, the pre-bronchodilator spirometry test, we will have the result of asthma and COPD quite similar. So whenever we administer some bronchodilator such as salbutamol with the dosage of 400 microgram, and we run another test and we compare the result from post bronchodilator administration and the pre-bronchodilator administration, and we focus on the number of forced expiratory volume at the first second. If there any increase in 200 milliliter, and also increase in 12% for FEV1 ratio to FVC. These indicate positive or we call as fully reversible test. So whenever you find fully reversible test, the patient most probably suffer from asthma instead of COPD, because most of the time, COPD patient doesn't really get benefit from the bronchodilator. So the next test will be, next slide please, the peak expiratory flow meter, previous, the peak expiratory flow meter, PEFM. So when it comes to this test, it's basically a benefit to detect airflow limitation but poor specificity. It is due to because uh, PEFM, we don't have any access toward the FEV1. So in order to diagnose the COPD, we need the number of FEV1 ratio to the FVC. So that's the main reasons why it's poor specificity towards COPD. Right, next slide, please. All right, will be the result interpretation for spirometry and peak expiratory flow meter. So I will focus on the PEFM first. The parameter will be, the unit will be liter per minute. If the patient is normal, the reading will be 400 to 600 liter per minute. Obstructive, approximately 100, and restrictive is 200 liter per minute. So when it comes to spirometry test, next slide, please. So you can compare the graph with the table that I've done. So if the FEV1 more than 80% predicted normal, then the patient will be normal. In obstructive, it's low, then predicted normal, and restrictive also low. So when it comes to FVC, obstructive patients will be have normal or slightly low. This is due to because FVC is forced vital capacity. If you see the graph, it will take the reading for the peak level of the line graph. So in obstructive patient, the obstructive patient will suffer from the emphysema. So emphysema, one of the character of emphysema is it's able to compliance, it's able to expand that, but lost ability to recoil. So that's the reason why during the first second one, FEV1, during the first second, the reading will be low, but towards the end, the FVC could be normal or slightly low, because we have a lot of air in the patient have a lot of air in the lung, but the problem with exhale it in a fast way. So when it comes to restrictive, FVC always lower than normal predicted. So when we compare the FEV1 and FVC post bronchodilator, whenever the ratio show below than 0.7, then you are diagnosed with COPD. But whenever the result normal or high than predict normal, it could be restrictive. All right, next slide, please. So this graph basically will present more precisely. You can see why the reason why the FEV1 ratio to FVC will be normal or slightly high in restrictive is it's because as we know that restrictive patients will lose the ability to recall the alveoli, will have a hyper recoil activity, but lose the ability to compliance to expand. So during the first expiratory volume, the first second, you can see the line will be slightly high than the obstructions patient. But towards the end, the FVC will be low because the lungs can't expand. It unable to expand. So that's why the air in the lung is very limited. So when we compare the FEV1 and FVC, it could be normal because the 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 number the the lowering number of FEV1 and FVC is in linear equations. So what does it mean? It's like the reduction in the number of FEV1 and FVC in a similar rate. So that's why when you compare it, it could be normal and it could be higher than a normal predicted value. So next slide, please. So this is the classifications of COPD severity based on spirometric impairment and symptoms. So first of all, if you can focus on the number, the reading of FEV1 ratio to FVC, it must it must to below than 0.7, then you are diagnosed with COPD. So what the differential between the different category between mild, moderate, severe, and very severe is based on your FEV1 reading. So whenever it's more or equal than 80% than predicted normal, with the presence of symptoms, then you are mild. So the rest you can read by your own. The reading will be taken the post-bronchodilator administration. So in order to create a better management for COPD patient, the the classification based on severity of spirometric impairment and symptoms also is slightly not enough because we need to evaluate the severity of the presenting symptoms also, especially when it comes to dyspnea and also the limitation of exercise. And there are several modalities that we can use to assess the severity of symptoms. So they are, next slide, please. You can use COPD assessment test, CAT. You also can use clinical COPD questionnaire, CCQ. Next slide. Next. And also you can use the modified MRC questionnaire. So all of these techniques basically is just a list of questions that going to assess the severity of your presenting symptoms. So with the classification based on the spirometry reading, plus with the result from this questionnaire, so it will be the doctors will have a better management for the patient. Next slide, please. So this is additional test that we can done to better prognosis and to rule out some certain differential diagnosis in COPD cases. The first one will be 6-minute walk test, 6 MWT. Basically, during this test is to measure the distance, how far the patient able to walk within 6 minutes. It is to test for exercise capacity and prognostic information. It is crucial to be done before therapy so that we can compare the result when patient already on therapy. So from that we can monitor the progression of the disease and also the benefit of the therapy that we given to the COPD patient. The second additional test will be a chest radiograph. When it comes to chest radiograph, it is really hard to rule out other differential diagnoses such as tuberculosis, lung cancer, bronchiectasis, and etc. So the characteristic of COPD chest X-ray will be the first one is a prominent vascular markings and evidence of fluid, and also the presence of bullae and hyperlucency. All right, the I forgot to insert another one chest X-ray basically. Because we know that COPD, the patient will come with the barrel chest, so it is indicate the hyperinflations of your lung. So through the lateral view of your chest X-ray, it is easier to appreciate the increase in the anterior posterior diameter of your chest. So when it comes to the bulle is basically pulmonary ascis, basically air space in the lung parenchyma. The measurement should be more than 1 cm. The hyperlucency appearance on the X-ray is basically due to the hyperinflation of your lung. So whenever your lung is hyperinflated, it traps a lot of air. So as we know that in the X-ray, air will appear hypodense. So that's why it appear darker. And if you can appreciate more on the hyperlucency X-ray slide, if you can see that the heart will be elongation and vertical orientation of the heart because the lung will push the diaphragms downward since the lung is hyperinflated. The next slide, please. So the next test will be your arterial blood gas analysis. It should be performed whenever the FEV1 comes out to be lower than 40%. If you refer to the grading system, it will be the stage 3 of COPD. So if the results show the hypoxemic and hypercapnic, then the oxygen therapy will be benefit for the patient. The next test will be blood count, full blood count. When it comes to full blood count, the common finding for COPD is the elevated of hemoglobin and the PEG cell value, because this situation occurs in the persistent hypoxemia, which is another response of our body with secondary polycythemia. And the keyword here, the persistent hypoxemia, as we know that asthma is a reversible condition, so most of the time the hypoxemia wouldn't be persistent. When it comes to COPD is a chronic progressive disease that by day the condition getting worse. So that contribute to the persistent hypoxemia. So whenever you found the elevated HB and PCV in the full blood count, that's how you differentiate the slightly can differentiate between COPD and asthma. The next test will be ECG. ECG is done in advanced pulmonary hypertension. Pulmonary hypertension basically is a type of increased blood pressure that affect the artery in the lungs and the right side of the heart. So in the ECG punya strip paper, the result you can see find P pulmonale, which is tall P wave. RBB is stand for right bundle branch block, and RVH stand for right ventricular hypertrophy. Right. As we know that COPD associated with increased airway resistance, alveolar and pulmonary capillary destruction, and also air trapping and chronic hypoxemia. All these circumstances will contribute to increase the workload of your breathing mechanisms. So in order to improve oxygenation of the blood, pulmonary vessels adjacent to underventilated alveoli tend to constrict. So which lead to the increase in both pulmonary vascular resistance and the workload of the right heart. So that's the main reasons why the abnormalities more onto the right side of the heart. So the next test will be the alpha 1 antitrypsin deficiency screening. We run this test, we run this additional test is only when patient below than 45 years old, which is a young COPD patient, and have a strong family history. Is basically to find out the etiology of COPD. And then the last test will be comorbidities. The comorbidities is basically we run a test to monitor other conditions that might be suffered by the patient. So here high listed fasting blood glucose, serum albumin, serum fasting lipid. Right. I'll give you an example like a diabetes. COPD could be one risk in the development of type 2 diabetes mellitus, and also COPD could be a risk factor that contribute to the uncontrolled diabetes. All right. The reason is because COPD patients is frequently admitted to hospital and be given a systemic corticosteroid. As we know that corticosteroid will increase the glucose level and increase the insulin resistance. So increase the risk of insulin resistance lead to the development of diabetes type 2. And whenever the patients already have a diabetes and also suffer from COPD, then the treatment of COPD will contribute to the uncontrolled diabetes. So that's the main reason why the test for comorbidities is done. Next slide, please. So we back to the ECG. As I mentioned, this is the some changes, the abnormalities that we can find in the ECG result, and also the underlying causes. And you may read it by your own after this presentation. Next slide, please. I think that's all from me. And any question? If there are no any more question, then I will pass the presentation to the next presenter. Thank you.
Okay. Good morning, everybody. My name is Koshta. I'll be presenting about the complications of COPD. Can you all hear me? Okay. Next slide. Okay, so I've listed down a few of the common complications of COPD. I'll be explaining this much in further detail in the next slides. Okay, so firstly, we have cor pulmonale and pulmonary hypertension, which is also known as the right-sided heart failure, followed by polycythemia, which is the increased RBC, acute exacerbation of COPD, pneumothorax and bullae formation, which is only found in emphysematous patients, and also pneumonia. Okay, pneumonia is actually one of the major causes of mortality and morbidity in COPD patients. This is because in COPD patients, we have excessive mucus secretion that makes the body even more susceptible to pathogens, and thus pneumonia occurs much more frequently in COPD patients. Other than that, we have respiratory failure and carbon dioxide retention. And this is because of the significant ventilation perfusion mismatching with a relative increase in the physiological dead space that leads to hypercapnia, hence acidosis. So basically, when a patient with COPD, they have a normal breathing pattern, and once they have COPD, they have a sudden rapid change in their pattern. So they tend to have more rapid, shallow breathing. Okay, and that causes a rise in their dead space per tidal volume ratio of each breath. So they tend to retain more carbon dioxide than excreting like before. So they can present with a physical examination. You can see the patient will have flapping tremors or a bounding pulse. All this is seen in patient with carbon dioxide retention. Okay, then we have frailty. Frailty is actually basically a term to describe being weak or delicate. Okay, we can use what we call the frailty phenotype indicators, which are basically composed of 5 components. I guess you can see on the right side. Okay, we have weight loss, self-reported exhaustion, low energy expenditure, slow gait speed, and weak grip strength. You guys can go through that later. But it is said that the prevalence of frailty by the frailty phenotype in elderly patients with COPD is 10.2%, which is basically twice compared to patients without COPD. Okay, next slide. Okay, so we're going through this first, which is the acute exacerbation of COPD, also known as AE-COPD. Okay, it is defined as an event in the natural course of COPD disease, categorized by a sustained, which has to be 48 hours or more, okay, of the worsening of patient's baseline dyspnea, cough, and or sputum that is beyond normal day-to-day variation in acute onset and also warrant a change in regular medication. So this is from the CPG. Right. So usually the symptoms are increased. They have dyspnea, cough, and now maybe the sputum is purulent, okay, in AE-COPD. And they also might have non-specific symptoms such as lethargy, insomnia, sleepiness, depression, and also confusion. So patients tend to underestimate this because they tend to think that this is a normal progression of the COPD. So they tend not to mention it to the doctor, because they don't understand the term exacerbation and so on. Okay, next slide. Okay, so we have two types of exacerbation, which are infective exacerbation and non-infective exacerbation. So infective exacerbation is basically almost 50 to 60% of the exacerbations are caused by bacterial or viral respiratory infections. Okay, like I mentioned earlier, pneumonia was one of the major causes of mortality in COPD. And I've also stated here a few of the other bacterial organisms that have also been found to cause AE-COPD, such as Streptococcus pneumoniae, Klebsiella pneumoniae, Pseudomonas aeruginosa, and so on. Okay, then we have non-infective exacerbation, which is associated with the increased airway inflammation. Okay, 10 to 20% of non-infective exacerbation is due to environmental factors or non-compliance to medication. And we also 30% of it is due to unknown etiology. Okay, as we know and as established earlier, cigarette smoking is one of the major causes of COPD. Thus, smoking cessation will be the most effective strategy in order to reduce the risk of exacerbation. Okay, other than that will be excessive physical exertion, severe allergy or inhaling irritating substances, and also stress and anxiety. Okay, next. Okay, so I'll be talking about cor pulmonale and pulmonary hypertension first. Okay, as we know in COPD patients, we have airway inflammation, increased mucus production, and also lung damage. Okay, all these factors may lead to airflow obstruction. Okay, when you have airflow obstruction, obviously we're going to have decreased oxygen supply to the alveoli and the terminal alveoli, and this leads to what we call an hypoxic alveoli. Okay, so this can initiate a hypoxic pulmonary vasoconstriction mechanism, which is basically the constriction of intrapulmonary arteries to redirect blood from hypoxic areas to more oxygenated or ventilated areas to improve gases exchange. However, this will also increase the blood pressure within the lung vasculature and can lead to pulmonary hypertension. And this occurs when pulmonary artery pressure exceeds 25 millimeter mercury at rest. Okay, so this increased pressure then will increase the workload of the right ventricle because it has to pump blood against that pressure. So that will also give rise to the occurrence of right ventricular hypertrophy. And with that, we have cor pulmonale, which is basically pulmonary hypertension and right ventricular hypertrophy. It is often presented with elevated JVP, hepatomegaly, pulsatile liver, peripheral edema, ascites, and pleural effusion, which are all seen in other heart failure problems as well. Okay, next. Okay, next is polycythemia. Like I mentioned, it's the increase in hemoglobin or pixel volume or a red blood cell. Okay, so secondary polycythemia is usually caused by the erythropoietin response in response to hypoxia. Okay, like I mentioned before, we have all these mucus and inflammation and lung damage. We have obstruction causing hypoxic alveoli. So when there's a decrease overall oxygenation in the lungs, there's a decrease in the partial pressure of oxygen, and this leads to chronic hypoxemia. And this chronic hypoxemia will soon occur in the kidney and will trigger the kidney to release increased erythropoietin production. And as we know, erythropoietin will lead to the increased hemoglobin and red blood cell synthesis that can eventually lead to polycythemia, which in male is supposed to be more than 0.51, and in female it is more than 0.48. It is considered polycythemia. Okay, next. Okay, then we have bullae formation and pneumothorax. I think this was mentioned actually by our previous presenter. Okay, so basically chronic inflammation of the distal airways occurs due to the due secondary to insults like the smoke from cigarette smoke or free radicals, like mentioned earlier. Okay, and all these can lead to the permanently enlarged alveoli distal to terminal bronchioli. So basically this is seen in emphysematous patients like I've mentioned earlier. And this eventually lead to what we call is the bullous emphysema, that is defined as spaces of more than 1 cm in diameter within the lung. So when we have an overload tension on these elastic fibers of the bullae, it is very fragile and is easily ruptured. So when it eventually ruptures, it causes the air to escape into the pleural cavity and introduce an excessive pressure change between the atmosphere and the chest cavity, thus leading to the lungs or part of the lung to collapse, causing pneumothorax. Okay, next. Okay, that is all from me. Any questions? If there aren't any questions, we can move on to the next presenter. Thank you.
Assalamualaikum. I have question. Can chronic asthma consider as COPD?
Hello. Anyone wants to answer that before I answer that question?
Can I try?
Yeah, sure. Siapa tu? Aisyah.
Okay.
Okay, right.
Okay. From what I understand, asthma is actually allergic reaction, while for COPD is come from the any substance that can cause inflammation. And then asthma usually it can reversible, while for COPD is irreversible respiratory disorder. So I think chronic asthma is can be considered as one of COPD. That's my opinion.
Okay. It's partly true, partly wrong. So the question was that does chronic asthma is considered COPD? No, but chronic uncontrolled asthma may cause COPD. I repeat, chronic uncontrolled asthma may cause COPD. Okay, so what do I mean by that? So as you all remember, asthma is an allergic reaction. Okay, like what Siti Aisyah has told us just now. It's an allergic reaction whereby the airway is hypersensitive to allergens, be it dust, be it animal fur, whatever, depending on the patient sensitivity. So when the patient is exposed to the allergen, the airways becomes inflamed, becomes edematous, and the symptoms starts. The coughing, the wheezing, the shortness of breath, the chest tightness happens. And when the inflammation stops and there's no more exposure to the allergen, patient is back to normal. Means that totally normal lung without any symptoms. Okay. However, if the process is recurring frequently in a prolonged period, then this chronic inflammation causes restriction of the airway. Therefore, in the end, after many years of uncontrolled asthma, you will get changes like COPD, such as muscle, small muscle cell hypertrophy, okay, and you will have your mucous glands hypertrophy as well. These would mimic COPD. Okay, so the only thing that could differentiate between patient who has prolonged uncontrolled asthma with COPD is first is based on the history. Is there any risk factor to smoke, be it home smoke such as dapur kayu, okay, biomass fuel, right? And the most common one is cigarette smoking. So you need to ask about that. If there is exposure to those smoke, then it's likely COPD. Whereas if there is no exposure to smoke, then most likely it is asthma. This thing you need to pay attention in patient who comes to you at an advanced age. For example, at 40 years old, 50 years old, okay? So most of the time, doctors will diagnose this patient as COPD just because of the age. Instead, this patient has been having asthma for some time and is not being controlled. And the asthma is so bad that it becomes COPD, okay? So that's how does chronic uncontrolled asthma leads to COPD, okay? Hopefully that answer your question. Who was it just now who gave that question?
Me. Thank you
Mustaqim.
for
Okay, Mustaqim. Jumpa lagi. Selalu bertanya soalan juga ada ni. Bagus. Okay. Anyone else? Any questions to the panel?
panel of presenters and to me. No. Okay. Honestly, I thought the ones who are presenting to me today are year 5 MD. It's very good presentation actually. I didn't expect you to go that detailed, and I didn't expect you to get it, how to say, correct on the details. Okay. There's a few things that, a bit of misunderstanding, but I think it's very minor mistake. But overall, it's very excellent presentation. I applaud to the panel of presenter today. Very good presentation, very good preparation. Nak tanya tadi, Muslimin ni orang mana? You had that slang, I noticed.
Tak,
Where you're
saya
from actually?
asal Sabah.
Sabah, no wonder you punya dad is Dutch. I noticed that slang there's somewhere, but ni orang Malaysia ni, tapi dari mana? Okay, but good. Yeah, you got the details right. You understand the topic you are trying to present to the audience. Very good. Just that need to touch a bit on the bronchodilator. You mentioned just now the bronchodilator won't give any benefit to COPD patient. Actually, it's not correct. Bronchodilator gives benefit both in short term and long term. Short term means that it improves the breathlessness, okay? And based on studies, long-acting beta agonists or long-acting bronchodilators, okay, it prevents exacerbation and thus improve patient's prognosis. Okay, your long-acting bronchodilators consists of your LABA, long-acting beta agonist, and also your long-acting muscarinic agent. Okay. So it's okay. Maybe you are confused with the reversibility test. Okay. What does it mean by reversibility test? It means to differentiate between asthma and COPD. As I mentioned earlier, asthma is an allergic reaction to the allergen, and that allergic reaction happens in the airway. Whereas COPD is a chronic process. You have your remodeling of your airway over years of exposure to noxious gas and particles. Okay, so when you do a reversibility test, in asthma, you expect the inflammation, the swelling, the obstruction of the airway to reverse when you give the bronchodilator. In COPD, you have that chronic changes already there, which is not amendable, not changeable with your bronchodilator. So therefore, if you give a bronchodilator after you do spirometry, then you won't, in COPD patient, you won't get that reversibility test result. Okay, because there's already chronic changes there. You may have some improvement in FEV1 percentage and the milliliters, but it doesn't reach the threshold set up by the guideline, which is your 12% and 200 milliliter. Okay, always remember that 12% and 200 milliliter. How do I remember this? Always remember the milliliters is bigger than the percentage. Okay, that's how I remember the numbers. All right, I tend to forget the percentages and the mils before this, so that's how I remember. So maybe you have some other methods that you use to remember those numbers, but it's very important for everyone, for undergraduates, postgraduates to know the reversibility percentage and also the milliliters. Okay. What else? Okay. So I think I just wrap up a bit about COPD. So in any diseases, you address the patient's complaint first. So for COPD patient, usually they will come with chronic cough. Okay, chronic cough, chronic breathlessness. All right. So if you come with patient with chronic cough and chronic breathlessness, you need to have some idea what is your differential diagnosis. Okay. First of all, chronic cough, it can be due to CA, which is lung cancer. It can be due to asthma. It can be due to what else? Bronchiectasis. All right. So you need to dig further into the symptoms. All right. From your symptoms, and you narrow down your differential diagnosis. Okay. So most of the time, COPD need to be differentiated with asthma. Okay. So the presenters just now, Aisha and the other panelists already presented what are the details you need to ask in COPD. So I just need to emphasize to everyone that you need to dig deep into the history to do differentiate between COPD and also asthma. Okay, next, go into the risk factors. Okay, so risk factors, like I mentioned earlier, any exposure to noxious gas and particles. Okay, always remember to ask regarding domestic noxious gas, dapur kayu. Okay, nowadays it's rarely used, but it's still possible in poor patients, okay, or very elderly patients, whereby in Kelantan there are still makcik-makcik, nenek-nenek yang still alive who use dapur kayu during their younger days, okay. And also remember that ladies do smoke cigarettes. Always ask about cigarette smoking history. Don't be ashamed, don't be embarrassed, or don't be afraid to ask cigarette smoking history. Okay, so always ask that. Maybe you think it's a bit sensitive. For me, how do I open up that question is like this. Kak, saya nak tanya sikit soalan ni saya kena tanya sebab ini sebahagian dari kerja saya. Kak isap rokok tak? So you give a warning shot first. So you see what's the feedback from the expression or not kan, and then you give the question. Most of the time, not most of the time, all the time, it's not offensive, so patient can answer the question, right? Next is risk factors, and next is your physical examination. For COPD, you need to pay attention on the lung hyperinflation. So what do you look for in lung hyperinflation is your cardiac dullness and liver dullness. In COPD patient with emphysema, the cardiac dullness and liver dullness will be lost. Okay, cardiac dullness and liver dullness will be lost because of the emphysema. Normally, there will be cardiac dullness and liver dullness. Okay, other than that, you look for at the hands for cigarette stain, okay, and you check for the oral hygiene, and then on physical examination as well, you look for signs of complications such as pitting edema that would suggest cor pulmonale. Cor pulmonale is related to pulmonary hypertension. Okay, and other than that, oh, I almost forgot. In upper lobe emphysema, you will have a reduced cricosternal distance. Okay, I think some of you did the PowerPoint on lung emphysema recently, right? So just to retouch on that topic. Okay, next, differential diagnosis, asthma, and if the patient does not seem to have the signs, symptoms, and risk factor, but he or she have wheezing and cough, need to think about cardiac asthma. Okay, cardiac asthma is when you have fluid overload, but instead of having the normal breath sound or fine cracks in fluid overload, the patient may have wheezing. Okay, this is because of the edematous airway due to the fluid overload causing the wheezing sound on lung auscultation. All right. So this kind of patient with cardiac asthma, if you give nebulizer, nebulizer, bronchodilator, they won't get any improvement. The wheezing will still persist, the breathlessness will still persist. So this patient need diuretics, and most of the time, cardiac asthma is usually comes in acute lah. It comes to ED with acute shortness of breath. Okay, and people will think, oh, patient ni is having acute exacerbation of COPD, but instead patient is having cardiac asthma. So despite giving a lot of bronchodilator, the condition does not improve. The only thing that will improve cardiac asthma is giving diuretic. So once the fluid is out, the airways open up. Okay, so how to differentiate cardiac asthma from your acute exacerbation of COPD or acute exacerbation of asthma is clinically the patient should look edematous. They will pitting edema, sacral pitting edema. Patient will have raised JVP. Patient will have fine crepitation or lung auscultation. And if you go into the symptoms, patient may have orthopnea, for assessment nocturnal dyspnea. So that will suggest of cardiac asthma. Okay. Other than that, there are the list of differential diagnoses. You can read in the GOLD guideline, like for example, lung fibrosis, patient can have chronic cough, but I won't go into detail about it. You can read it online in the PDF. Next, you need to confirm your diagnosis of COPD by spirometry. Itu wajib, need to be done. So because you need to differentiate between asthma and COPD. Why? Because the treatment nowadays is different between those two. So asthma, you want to give ICS early on. In COPD, you should delay ICS until the last spectrum of disease severity. So means that the worst patient, then you give ICS in COPD. Okay, so you need to differentiate that. So remember, asthma, give ICS early on, COPD, give ICS the last. That's based on the latest guideline. Why? ICS causes a lot of complication. The most worrying in COPD patient is pneumonia. Okay, so other than that, for inhaled corticosteroid, it doesn't cause systemic complications such as diabetes or whatnot because it's locally affecting the lungs only. That doesn't go into the system. Okay. The most worrying thing about ICS is pneumonia. So we try to avoid ICS in COPD. Only in certain patients in COPD group D, okay, they may benefit from inhaled corticosteroid. All right. Other than that, you need to manage, investigate, and manage other comorbidities like Muslimin told earlier. COPD can affect these comorbidities, and these comorbidities can affect COPD. So, if you don't manage all of these diseases together, the patient won't improve. Okay. Next is management-wise. You need to manage non-pharmacological first. Always remember to ask patient to stop smoking. That is the rule of thumb. Okay. Advise them to stop. Or if they need help, they can go for quit smoking cessation clinic. And nowadays, in lots of hospital, we have this service. Okay, they can give pills, they can give nicotine patch, depends. As long as patient is willing to stop. Okay. Next is you need to address in anything, in any management, you need to address the non-pharmacological management first. Okay. So non-pharmacological for COPD would be good nutrition is very important, especially in severe COPD where the patient is already emaciated, very thin, very cachectic. So you need to address nutrition. Okay. You need to address the social support as well because COPD patient, especially the ones with very severe, they need support with the family. They need to move around with help. Okay. Need physiotherapy. All right. I think our presenter already presented earlier, so I won't get into detail on the non-pharmacological management. Why do I emphasize non-pharmacological management first? Is because we tend to forget the non-pharmacological management. So we tend to give pharmacological management first. We tend to give drugs, we tend to give inhalers, we tend to give all these medications to the patient, but we forget to consider things that doesn't need medication. Okay, so after you finish with all your non-pharmacological management, then you go to your drugs, inhalers, right? So the inhalers purpose is one, short term is to reduce disease burden, which is your breathlessness. And next, you need to reduce the rate of exacerbation or avoid exacerbation totally. Why? Exacerbation is associated with death, okay? And also worsening lung function. So if patient is having frequent exacerbation, he or she over the time will die early, or he or she will have a progressive disease. Initially can walk 100 meters, but after a year or two of frequent exacerbation, they can only walk like from the bed to the toilet only. So we need to prevent exacerbation. Okay, how to prevent exacerbation is your long-acting muscarinic agent, ipratropium bromide, okay, and your long-acting beta agonist ada macam-macam, salmeterol, formoterol, okay. Your inhaled corticosteroid is only for severe group D patients, okay, who fits with some criteria, which is eosinophil level, which is should be more than 300 or more than 100 plus frequent exacerbation, okay. If patient does not fulfill that criteria, avoid giving inhaled corticosteroid, okay. And what else? And you also need to manage the complication. If patient having copulmonale, if patient is having fluid overload, you need to give oxygen. Give diuretic. If patient is having chronic hypoxemia, you need to consider giving long-term oxygen therapy. That will improve patient's condition, breathlessness-wise, and also to improve patient's prognosis. Okay, so long-term oxygen therapy helps to prolong patient life as well. Okay, but for very severe COPD patient, all right. So I think that's the wrap up of today's COPD tutorial. Any questions? No question. Sekejap. Tengok ada
I have
ke tak.
one more. Is it
Mr. Kim,
important
yes.
to divide emphysema and chronic bronchitis like blue blotters and pink puffer?
Good question. It's good to know, but clinically impractical. This is basically old textbook interest. Nowadays, it's good to know, but in clinical practice, you cannot differentiate between those two because one, our population, Malay, Chinese, Indian population is not pink, all right? So you won't get the pinkness appearance in COPD patient. Mostly yang pink-pink ni Caucasian lah, white people lah. Okay. Plus, you can have a mixture of both. So patients with emphysema, they can have a chronic bronchitis. Emphysema can have chronic bronchitis. Okay. What is the purpose of the authors coming out with the pink puffer blue blotter is to highlight the extent, the spectrum of COPD manifestation. But in reality, it's actually a mix of both. Okay, so it's okay to know. Maybe your examiner will ask, do you know about pink puffer, blue blotter? Yes. Just tell them pink puffer is more of emphysema, whereas a blue blotter is a chronic bronchitis. But when you start working, it's not used anymore, actually. Most important thing is you need to know how to diagnose, how to investigate, and how to manage COPD patient when you start working. All right. Hopefully that answer your question, Mustaqim.
Alright, thank you.
Welcome. Boleh. Yes, good, good, good. In any settings, if you have patients with thick phlegm or thick secretion, you need to help the patient to cough up that secretion because it can cause a lot of problem. Can cause discomfort. Patient already breathless and need to cough it hard to expectorate that phlegm. Okay, and that will cause distress to the patient. And thick secretion, thick phlegm can also cause blocked bronchus, causing atelectasis. So therefore, there is role of mucolytic, but not in a chronic, prolonged period of treatment. You give only in short duration. For example, patient in acute exacerbation and patient complain of thick phlegm, then you can give mucolytic. But once patient already out of the exacerbation, you discharge home, you shouldn't give mucolytic for a long period of time. Okay, maybe once a while when patient needs it, then you can consider giving it. Okay, because mucolytic only improve the symptoms of thick phlegm, but it does not improve patient prognosis. Okay, you shouldn't confuse COPD with bronchiectasis. Okay, bronchiectasis, the mainstay of the treatment is mucolytic, but then again, it is given in short duration rather than a prolonged duration, and when the patient needs it. So you shouldn't take daily. You should give in like 1 a week or 2, and then once the symptoms improve, and then you stop it altogether. And when the symptom comes again, then restart again for a short duration. Okay. So what Command Clark want to say that is right. So there's a role of mucolytic in COPD, but what the guideline is showing is the mucolytic is like macam adjunct additional treatment to COPD. Okay, they don't want doctors to mistakenly give mucolytic for all COPD patients. All right. Hopefully that answers your question, Amirul. Welcome. All right. Anyone else? So yeah, an hour and a half. Okay. So I'll be sharing you the attendance link after this. I'll forward to Amirul. In the attendance form, there will be some quick questions, right, for you to revise on today's topic to enforce your memory. And there will be a feedback section as well. Please leave your feedback there. And I think that's it from me. So thank you very much again to the panel of presenters today. Very excellent presentation. If you have any questions, you can contact me on WhatsApp or email. Okay, I had received some questions over the past 2 weeks. So very good initiative. So I'm looking forward to listen or have questions from you guys. And inshallah, we will see you again after like 2 weeks. Okay. So that's all. Thank you very much. So kita habiskan tasbih dengan sesi kita hari dengan tasbih kifarah dan surah Wal-Asr. Okay, for the link after this, yeah. Right. See you. Bye.
Thank you, Doctor. Thank you, Doctor.